Welcome to the Coptimizer Podcast, a platform dedicated to uncuffing your true potential in public safety. We're here to provide you with valuable tips and insights that will help you optimize your life and career. I'm retired Chief Patrick Flannelly, and I'm honored to be your guide and coach on this journey. Here, I'll share the latest insights and strategies to help you survive and thrive in the demanding world of public safety. Our noble duty is to protect and serve. We embody the role of peacemakers in our communities. However, this profession's immense physical and mental demands come with a price. If we fail to take a proactive approach for our well-being and lead ourselves first, then the stress from the job can and will lead to poor health outcomes. We have all seen it play out. Not only does this impact our professional and personal lives, but it also affects our ability to fulfill this sacred duty. Like many of you, my journey has been filled with tremendous challenges, with highs and lows. However, through creativity, experience, and a positive attitude, I successfully managed over 30 years in law enforcement, emerging healthy and happy. Now, I am driven to share what I've learned to show you that the path is not all doom and gloom. There is hope and a profound purpose in serving your community, and I'm here to show you that it does not have to come at the cost of your health and well-being. Join us as we explore cutting-edge research, interview top experts, and share inspiring stories of transformation. Whether on duty or off, it's time to optimize your potential and live your best life. Get ready to be inspired, informed, and empowered. This is the Coptimizer Podcast. Greetings, all. Welcome back to another episode of the Coptimizer Podcast. And as usual, I'm super excited about our guest today, Dr. Chris Frueh. I'll give a brief intro, and then I'll kick it over to him to do his intro. But he is the author of the book Operator Syndrome. And I reached out to him because in three separate conversations within a few week period, people had asked me if I had read this book or if I had him on the podcast. And I had his book in my queue, and I've since read it and wish that it's a book that I would have read a couple years ago. Um, Amazing. But Chris is a clinical psychologist, a researcher, and I think for a lot of the work that those of you who listen to the podcast might be familiar with our metabolic reset project and things that we talked about as quote cop optimization really align with the really important work that Chris does. And uh, I had a whole page here, and I'm not even going to read it. I'm just going to flip it over to you, Chris, and maybe let you describe in your own words what is operator syndrome and why do we think it's going to be important to cops? And then we'll get a little bit of background on you and go from there.
Sure. Well, I love it. We're jumping right into the bottom line up front, which is, and it started with military special operations, which is which is where I've been working within that community for about 12, 13 years. But the bottom line up front is that a career in special operations, police work, firefighters, and many other of our warrior protector class, including those other soldiers in the combat arms, that these careers involve what I would consider to be a massive dose of allostatic load, and it's cumulative. That allostatic load builds up and it collects over time, and it has an effect on all of the human physiological systems. So where that takes us is we need to start doing a better job of understanding that to be a police, difficulties aren't just psychological. They aren't simply PTSD. That's what happens when soldiers and responders raise their hand and say they're struggling. They tend to be quickly diagnosed with PTSD, which unfortunately means we're dismissing and not paying attention to the physiological injuries that are throughout their systems. So this cumulative allostatic load, this is a hypothetical term that refers to essentially everything that goes on to a career. So it's sleep deprivation, it's circadian rhythm um, disruption, it's chronic stress on body and joints, it's head injury, it's psychological as well, it's metabolic. And so all of our physiological systems uh, are engaged. And what we end up with is a constellation of very complex, interrelated injuries and impairments. And I talk about this from the perspective of several different kind of perspectives. One is performance optimization. We want to help our soldiers and responders optimize their performance so they can do their job as well as possible for as long as possible. But we also want them to be well. We want them to feel good. We want them to have quality of life. We want them to flourish in their family relationships and for the long term after they take the uniform off. So the concept of operator syndrome, it's not a medical diagnosis, but is a framework to begin to understand this constellation of interrelated injuries and impairments.
And there's a presentation that I show in the work that we do with our metabolic reset project, and it comes from The Simpsons. Chief Wiggum, and it's meant to be humorous, but at the same time also maybe capture our attention because it shows the overweight, obese cop with the donuts, and
Mm,
we get a good laugh out of it. And the question that I always have at the end of this is if we know that 80% of police officers in America, this is according to FBI statistics, 80% are overweight, around 40% are obese, and now approaching 20% morbidly obese. What's really funny about that? And what, do we ever take a step back to contemplate why is that? Because we have these strict standards for getting hired. You get into an academy, you have to train to meet these standards, and then this creep sets in once we're out of the academy. Of course, we can talk about fitness standards and things like that, but I like to dig a little bit deeper into maybe some of the biological functions that are occurring that might be
right.
driving some of these things. So it's not, where we just can't blame the fat cop. Hey, you're lazy. Go
Yep.
eat better.
Yep.
Eat a clean diet and exercise better. And like, what does that mean? And so when I read your book, all these things were just all these gears were just clicking and clicking and clicking, right? Because you really talk about um, like you just said, it's not operator syndrome isn't a diagnosis, but it's a framework really for understanding how chronic stress, sleep deprivation, TBI, brain injury, which a lot of cops have,
Oh yeah.
endocrine dysfunction, which we look at through from the process of doing labs, collecting data. Imagine that cops actually collecting data to try to understand a problem. Just pain. And then on top of that, then we don't do a good job at all about what happens to our cops after they retire in terms of their identity on the job and then where things go um, when it's done. So anyway.
Well, let me go down my list. And you said a lot of it, but let me just go through the list of operator syndrome, the areas or the issues, just so we can kind of capture this, and then we can then start to discuss around it. So, operator syndrome, whether we're soldiers or responders, includes traumatic brain injuries, sleep disturbance plus sleep apnea, hormonal dysregulation. For men, that typically takes the form of low testosterone, elevated estrogen and progesterone, low human growth hormone. We we know a lot less about what it means for females, but there seems to be really strong anecdotal evidence that at the very minimum, females experience high rates of infertility, miscarriages, and early menopause. Those are all hormonal.
Wow.
We see, of course, we see psychological issues with depression and anger and general anxiety. Substance abuse, especially alcohol, is a real concern. It's both a coping mechanism, but it's also a sort of a cultural way of coming together and being together in many departments and units and groups. We also see impairments to perceptual systems. So hearing, vision, and balance are often affected. That's often secondary to TBI. Chronic joint pain, very common to have just debilitating chronic pain in shoulders, elbows, hips, back, knees, ankles, neck. And then we get into cognitive impairments, impairments into concentration, short-term memory, being able to stay organized, and even learning new things. It's very hard to learn new things if you have a traumatic brain injury. All of this, and again, remember, these are all interrelated. So pointing the finger at one of these and saying it causes everything else isn't really possible. Um, we get to cardiometabolic dysfunction. That's obesity, that's diabetes, that's insulin, uh, you know, insulin reactions, blood sugar. It's cardiac functioning. It's higher risk of cardiovascular events or disease. And all of these go together. I mean, think about it. If you're not getting good sleep, what happens during sleep? Well, during sleep, that's when our metabolism is doing certain processes, maintenance and regulation. It's when testosterone is produced. So our hormones are being managed and regulated at different stages of sleep. So you injure one part of the body, the human body's as a system, and it's going to have effects that are going to roll out to everything else. And then the physiological systems roll into the social systems. So marriages, families are affected. Intimacy, both emotional intimacy and sexual intimacy, are affected. We know there are toxic exposures that are, that occur on the job that can lead to long-term problems with breathing, with respiratory health, with, higher risks of cancers, things like that. And then you have the transition points and the existential concerns, which can cover a lot of different things. With soldiers, we often talk about the transition to civilian life. Um, but with first responders, we have to think about the transition that occurs at the end of every shift. You're out there in the streets and then you're home a few minutes later, and all that stuff from the day is still with you. And what's the process for decompressing between the streets and home? And unfortunately, too often alcohol is part of that transition, which is understandable, but it's also very damaging. And then, of course, the existential concerns, which are never going to be the same for any individual, but there's a wide range of them. And they do include loss, grief, rage. They do include things like survivor's guilt, moral injury, the sense of hey, I'm out here in the streets, and where's even the support or appreciation from the community and the state and the nation? Um, Loss of empathy. How do you stay empathic with your family you've habituated and you've hardened to seeing terrible things in your work? Loss of tribe, loss of mission, loss of purpose. These are things that soldiers and responders really struggle with when they take off the uniform for the last time. Who are you? What do you do now? Where do you go? Who do you relate to? And what do you matter? What do you mean to the world? What's your purpose? So yeah, I just said a whole lot of shit, and it is a bunch of shit, and it's all super
I didn't want to interrupt you. Like I'm terrible at interrupting, so I'm like, I'm going to keep my mouth shut. I got the expert here, and
And here's
I
and
just
here's
want to
part of
listen.
And here's part of the shame of it all is we haven't really yet, widely, broadly opened our eyes to this. And too often, we tell a warrior who goes for help, who doesn't, can't put this all together. You know something's off. You know something's not right. You know you don't feel well. You know you're not functioning the way you used to function, but you can't put your finger on what it is easily. So you go to the medical establishment, and who pretty quickly are going to tell you you have PTSD almost automatically. It's a big, great big red easy button that primary care and behavioral care are gonna push. And from there, the algorithm is here's a bucket full of psychiatric medications. And so we're going to medicate you, probably over medicate you or mismedicate you. And here's a therapist. And the therapist may be really good at their job, but odds are they are not going to be very well attuned to understanding the culture and experiences of police. And they may even be terrified when they start to hear about the lives and the experiences. And they may come to those sessions with some biases of their own that aren't so helpful or
Yeah,
useful.
I've heard stories about uh, new police, um, social workers and psychologists not lasting long because they're it's too much for them. And
I can give a talk to a room of 100 soldiers, 100 veterans, 100 responders, and I'll tell a story, a true story of a warrior who goes in for that first therapy session, and 20 or 30 minutes into it, the therapist is more distraught, more distressed, maybe crying, more upset than the warrior. And the warrior just has to go, well, sorry, I ruined your day. And they're going to walk out. They're not going to come back. And when I tell that story to that room afterwards, 10 guys will come up to me and say, that's exactly my experience. And so we've created a failure point in our mental health system. And the other failure point in that system is this. It's the duty to report on fitness. So our mental health practitioners in the military and in the responder community often have a responsibility to report on that warrior's fitness for duty up their command chain, which inevitably means they're going to be taken off duty and given desk job, which might last for a year or two or three or more.
yeah, it can, and it just depends on what the circumstances are. Thankfully, I will say because of the work that you're doing and others, w- some of those barriers are starting to fall. Police leadership, only speaking for the police community, police leadership is, I think, getting better, but we're just so far behind. We just got a late start, and the sad reality is if it wasn't for some of the tragedy that was happening, on a public scale with our soldiers and our veterans, then I don't even know that police officers would be getting any attention at all. And the rates of suicide for cops tend to run higher than our military population. Just depends on which data you look at, and again, is in terms of data, it's frustrating because we just don't have very good data.
Do you
And
have if I ask you, and I ask guys this all the time when I'm doing one-on-one coaching, but I'll put the question to you, Patrick. How many soldiers, how many police, how many firefighters come to mind that you personally have known who've died by suicide?
Fortunately, not zero on my own agency, but probably four or five over the last 20 years from, our surrounding area, people that I knew.
Okay. Mhm.
Where more tragically, I guess, or just equally as tragic is heart attacks, strokes, then
Yeah,
things
there's
that
other forms of mortality for sure. I mean, that's the other
just
piece of it.
dying way too young. Yeah.
Yeah, early mortality, dying way too young.
And yeah, I don't, and on our call a couple weeks ago when we were just chatting to get ready for this, I shared in law enforcement circles, everyone is very familiar with Dr. Kevin Gilmartin and his book, Emotional Survival for Law Enforcement. And I mean, he's a retired police officer, police psychologist that's been doing this work for a long time. And he talks a lot about hypervigilance later towards the end. And, with our friend Dr. Greenwald that's on the call here, those two have been friends for a long time. But he started to shift some of his conversations even to metabolic health as, one of these drivers. But overall, his book, I think it does a really good job of kind of framing what officers feel like as a result of
Mhm.
their experiences at work and coming home. And like kind of you said, like the loss of empathy, right? What he would say is like, why are you an asshole? It's like, your family is like,
Yep,
you
yep,
go home, you
yep.
sit in the magic chair, admin, everything at work, it's all freaking bullshit. Everyone's an asshole. And then their family are like, well, you're the asshole.
You're
And
the asshole. Well,
uh,
I mean, you used the word I easily could have used, and what guys will often say, and gals too, is that they have simply become perceived to be by everybody around them as impatient and insensitive, not empathic, not seeming to care. Um, and the one way of understanding that is it's a habituation to adversity. You see adversity all day long, and then you come home and you're talking with your kids or your spouse, and their version of adversity may be very, very different. That threshold, that set point for when does something count as adversity or trauma, may be very different.
and again, that's why I really like where you discuss allostatic load. And this is not stuff that's taught to cops. I mean, I think we're in wellness classes and things like that, and some of your more progressive and forward-thinking organizations, we are getting better at teaching what what stress is, what stress isn't, when it's good, when it's not good. Um, and then, some of the things like me personally and my work with Dr. Greenwald knows at Specialty Health and others, like what we're trying to do is raise awareness of what is the byproduct of that accumulated stress over time, how it's impacting your endocrine system, your metabolic function, and how those things, and you mentioned it earlier, kind of, one thing can lead to a cascading issue of problems. Like it just doesn't stop there. And so if
And
you
they're
have,
iterative.
yeah, I'm sorry, go ahead.
I'm sorry I interrupted you, but they're iterative. If
Yes,
you
yeah.
injure your brain, it makes it harder to get quality sleep. But quality sleep is what your brain needs to heal itself. So we get into this vicious cycle where a little bit of a brain injury causes insomnia, causes changes to metabolic functioning, causes changes to hormonal functioning, and those in turn make it harder for the brain to fix itself. So now the brain may be getting worse. And that just, so it's a vicious cycle. And I think what you guys have been talking about and trying to do, and what I'm talking about and trying to do is enter that vicious cycle. And we can enter it at a lot of different places. Uh, If we fix sleep, if we help with hormone health, if we help with cardiometabolic health, and if we do one of those things, it starts to change that vicious cycle into potentially a more virtuous cycle. And then if we can address three or four of those clinical targets, um, we have hope for some really good outcomes. And that's the other piece. Like, we got to be hopeful because there is hope. We have treatments, we have interventions, we know how to help. We just are not doing it at scale.
Yeah, there was some data that I saw. I mean, again, while we've gotten better at providing the resources, that oftentimes if the resources that you have, if you don't communicate well about the intention behind the resources, then people might shy away from using it. They don't want to get
Mm-hmm.
labeled. They
Hmm.
don't want to be uh, taken off of the job, or worry about promotion or something like that down the road, or even just more plainly just being concerned as appearing as weak, or and that's problematic. And that leads really to generally what happens is somebody gets in themselves into a crisis They have a major, issue at work, maybe a disciplinary issue, a behavioral issue, and nowadays with body cameras, a lot of those things play out very publicly,
Yeah.
and where one punch might have been necessary and sufficient, two might have been a little bit heavy-handed, but still justifiable. But then, next thing you know, you've got 10 to 12 punches and things just turn, the appearance is, wow, that's just an angry, bitter cop. And kind of going back to my donut joke earlier, there's really no consideration at that point for, well, what led to that? What were the processes that led to him to snapping or, having that loss of emotional control? And it's because even if they have resources, there's a strong possibility that they're not using it. And then they
Mm.
have this incident, and now even then we're looking at right around 17 to 20% engagement with those services. So we definitely need to get out in front of the problem, do some prehab work and, rather than the rehab, yeah, after the fact.
If I could mention one of the perspectives or approaches that I've developed a lot of appreciation for in recent years, like the last 5, 6, 7 years, is the value of peer coaching in some form or fashion. And there are foundations that do this for veterans and first responders. I'll mention Boulder Crest. Boulder Crest has a peer coaching model. They're a foundation. They serve veterans and first responders. And the idea is sometimes you got to talk to somebody who's not a PhD, not an MD, not a social worker, not a trained therapist. And they do have some structure built into what they do. Um, that's a good one. Some of the special operation foundations run their own peer coaching and health guidance programs. SEAL Future Foundation is one really good example. A SEAL, a retired SEAL, can call the number and they're going to talk to another SEAL. And they're going to talk to that SEAL who's been there, done that, lived it, had a lot of the same health problems, and they'll talk through whatever's going on and they'll help them think about what some of the solutions might be. They can make some recommendations and then they point them to referral to their referral network and then they pay for the care because a lot of this is not a lot of the good treatments are not covered by insurance. So they'll send a
Yeah.
guy, hey, we're going to send you to Mexico for psychedelic training therapies, or we're going to send you to this clinic to have your hormones tested, and then this doctor is going to um, provide the medical care to get your hormones regulated. Another group I work with that I actually am employed by, a small part-time role, is Sharp, a group called Sharp Performance, and their concept is former special operators serving as one-on-one coaches for police and fire, and kind of, I mean, they come to that conversation not with a history of responding, but as a history of putting their lives on the line and being elite, protectors, warriors. But they've also gone through their own health journey in the process, so they're there to be a resource and to help guide others through that. So that's one of the places I'm putting a lot of my future, a lot of my hope for the future is not looking to established medicine for solutions entirely, not relying on the medical establishment or the behavioral health establishment, but looking towards some of these groups that are coming along to say, hey, we haven't been doing this well. And the current way we've been doing it, or the way we've been doing it for decades, is either suboptimal or in some cases very harmful.
Well, and that's what Greenie will say, right? It all starts with the correct diagnosis, and then once you have the right diagnosis, then you can start a pathway to healing. And yeah, like from our perspective on the metabolic health side, it's just, yeah, the establishment is very entrenched, and it's
Mhm.
difficult to get people to open up and tend to look at alternative treatments. And I definitely want to get into some of those. I have a ton of questions. We wouldn't have enough time on today's podcast, but Ibogaine and some of those other ones that I've been hearing a lot about the treatments. There are centers that have opened up here in the Midwest, I know, that are using some of these alternative treatments for police officers that are having PTS and other diagnoses. But I want to take a step back real quick because one of the things I just find it really interesting. When when did you first kind of realize that this is like, I don't know, a constellation of issues, and was it intention, was your path intentional to go work with special operators and then eventually with first responders, or was this just kind of something you were seeing and saw gaps and got involved in because I don't know. I find it really fascinating sometimes when I see people like working in our space, because there's a lot of other things you probably could be doing, and
Mhm,
we
mhm.
really appreciate your work.
Yeah. So as you're asking, what's the story? How did I? Yeah.
How did you get here?
Yeah.
Yeah,
How did I get here? I sometimes
as
ask
the days go by, right?
the days go by. Yeah. How did I get here? Well, I'll tell the story a little bit. I won't make it a long story, but I started graduate school to become a clinical psychologist in 1987, which was 7 years after PTSD had been added to as a diagnosis to the psychiatric nomenclature. So I didn't even know, I'd never heard of PTSD when I started graduate school. But what I had heard of, what I did know, was that soldiers historically experience psychological difficulties coming back from wars. And I knew this from my father, who was in the Air Force and deployed as a physician during the Vietnam War. And I knew this from my great grandfather, who died at the age of 99 when I was about 14 years old. And he was a veteran and fought at the Battle of San Juan Hill in
Wow.
Cuba during the Spanish-American War. So I went to graduate school with some sense, some awareness that war profoundly affected soldiers. And I guess that's about all I could say at that of what I thought at that time. But I wanted to work with veterans. That was kind of my reason, my goal when I went to graduate school. And I was able to accomplish that. I was able to do that. My last year of training was at the VA Medical Center in Charleston, South Carolina. And then when I finished my degree, I stayed there and I worked there for another 15 years at that VA with an appointment at the Medical University of South Carolina there, so jointly appointed. And so those 15 years, I was in a PTSD clinic, and then I started doing research. So I was both serving as a clinician as well as doing research on PTSD in veterans. And if we fast forward to today, I'll just quickly give the my academic summary. I've been in academia my whole career. I've been at three different medical schools, two in Houston, Baylor College of Medicine, and the University of Texas Medical School in Houston. Now I'm at the University of Hawaii in a non-medical school setting. Um, so I've always taught a little bit. I've always done research. I have over 300 scientific research publications, dozens of federal research grants. But one thing I never really stopped doing, which is unusual for people who really are successful with research, I never stopped um, talking to patients. And while I worked at the VA, the last few years I was at the VA, I was no longer a full-time clinician, but I always carried at least 25% of my time was in the clinic. And then about some years ago, while I was working in Houston, this 12 or 13 years ago, I was invited to a happy hour that was sponsored by a group of former special operators. And I was invited there as, hey, you're a psychologist, you're a PTSD expert. Come on, just come hang out with us and meet some of the guys, and maybe some good things will happen. And what happened from that was just some very organic conversations. Some of it was, over beers, some of it was over breakfasts or coffees or whatever, but it was all informal. It was all off the books. And guys started, talking to me And they could talk to me, I think, in part because I wasn't part of the military and I wasn't part of the VA at that time. And I wasn't writing things down. I wasn't keeping records. So there would be nothing to subpoena or anything of the sort. And I made a very, very dangerous and wrong assumption at the beginning, which is the assumption that I think any psychologist or psychiatrist or social worker or therapist would make, which is, oh, you're struggling in life, must be PTSD. I made that assumption. I made that assumption. But I quickly realized my assumption was wrong. Those guys didn't, for the most. I'm not saying there wasn't PTSD. Obviously, there were some symptoms, but that wasn't the core problem. And so then I started like, well, let's get some testing done here. And so I spent probably 6 months just kind of trial and error testing with all of these guys. And what quickly emerged was, and I started with a handful of 6 or 7 guys. They all had low testosterone. And that shocked me because these guys were in their late 30s, early 40s. Here's a guy who was on the Bin Laden raid a few years ago, and now he's out of the service, former Navy SEAL, and his testosterone is the testosterone of an 80-year-old man. Did some brain scans, put him in an MRI, looked at the brains with a neurologist friend of mine, and his first comment was essentially, these brains look like healthy brains of 80-year-old men. There wasn't anything that would jump out at you as like a tumor or a lesion or something that was dramatic, but what he was looking at was the ventricle atrophy in the brain. He's like, yeah, these look like aged brains. Well, pair that with the brain and pair that with the hormones of an 80-year-old man. And you don't have to go very far to realize something is really, really effed up here. And it's not what we thought it was. It's not what we were looking for or expecting. Then I discovered they all had cardiometabolic problems. They all had sleep apnea. Like sleep apnea, what get the heck out of here. What the hell are we talking about? That didn't make any sense to me either. We didn't know much about blast exposures at that time. I certainly didn't know anything about it. Worst, we've learned a lot, but that information hasn't really gotten out into the practice community very well. Um, And I'm going to say this, 15 years at the VA, I had never worked with somebody from special operations. I'd never had a patient who was a SEAL, a Green Beret, a combat controller, a raider. I'd never had a patient from that community. I left in 2006, just as the veterans from the global war on terror were starting to trickle into the VA. Um, but when I first started talking to these guys, I didn't even understand their experiences. I didn't understand that they had multiple deployments the way they did. I didn't understand the training evolutions. I didn't understand that they would go and stand on a field and shoot Gustav rockets all day long, or what that meant to them, what that did to the brain, to the gut, to the body. We published a paper in 2020, a medical paper. It's online, Operator Syndrome 2020. You can find it. It's free. It's accessible. You can download the PDF. It's an easy read because it's descriptive. And published that paper. It was literally just a descriptive paper describing what I've just been talking about. And it did the equivalent of going viral in the operator community. Suddenly, operators were um, sharing that paper with each other. A year later, I was at a community event in Fayetteville, and I was introduced as the author of this paper. I was just in the audience. I wasn't there to present or anything. I'm just sitting there, and suddenly I'm being recognized, and I got a standing ovation. Like, what? Where? I was
That's cool.
I was literally sitting in front of a Medal of Honor winner. He didn't get a pat on the back. That was kind of my first clue of holy cow, this is tapped into something that's really big. And later that year, a firefighter, Canadian firefighter named JD Miller reached out to me and we started having conversations. And she was saying, she'd seen me on a podcast, she'd read the paper and said, wow, I'm in the career firefighter. We have these same issues and challenges for the most part. And after diving into it, I was like, wow, firefighters really do. Police really do. And so what started with special operators is now clearly a relevant concept for first responders to begin to understand and to begin to learn how to manage, to treat, to mitigate all of that.
Well, I read that paper, and in addition to the book, and I do for anyone that's listening, we'll throw a link in the show notes for it, and obviously a link to the for the book too. But read it because it does it. I think probably why it resonated so powerfully is because you gave a lot of people explanations about things that they were feeling and experiencing, where in the past it was considered probably more psychosomatic, right? Like, hey, it's all in your head. You
Yeah,
you
yeah.
know, just get
It's
a
all,
better night's sleep, and go for a walk in the woods or something, and tomorrow you'll feel better. And not to say that both those things aren't important, but it's you once you kind of start thinking, okay, well, I maybe it's not just me, and maybe and because cops, we call it the car to car conversation, right? Like if you're pissed off at admin, or you're debriefing a call that you were just on, you pull up to your partner and you sit there window to window and
sure,
you
sure,
solve all the world's problems,
sure.
and eventually some of those conversations do get really personal because you trust your partners. Cops trust other cops, and you share things that you're probably not going to share outside of that environment. And yeah, like yeah, the one I definitely want to dig in a little bit on the testosterone too. And I'll give my own experience here because I loved working the night shift. And by the way, we have Charleston, South Carolina in common because I did see that in your book, and that's one of the reasons I wanted to just mention that. I was stationed at Charleston Air Force Base for 3 years.
Oh, right
Yeah,
on.
I
Okay.
left right before Hugo hit. So,
You
and
left
I
just
went from,
before. Okay. We didn't
yeah,
overlap because I arrived, I think a year and a half after Hugo broke.
yeah, a lot of my partners are still down there, but I went from there to Galena, Alaska, and most people have never even heard of Galena, but
You went
it's
from you went from coastal Carolina to Alaska. Nice.
yeah, I figured it was my first duty assignment, and I loved it, man. We had a great time. I had too much of a great time. Um, and I figured, you know what? I've only got a year left, and I knew I was going to be getting out and going to Purdue, and so which was in my hometown. So I'm like, I need to go do a remote tour. So I put in
Okay.
to do a remote tour.
So you chose that PCS.
I did, yeah.
Cool. That's really
Now, and I got there. Galena, just for people that aren't aware, it's about 450 miles northwest of Anchorage, Alaska, right on the banks of the Yukon River, about 100 miles south of the Arctic Circle. So, I mean, you are way the hell out there, and it was great for like the first 2 months. I loved it, and then it was pretty much dark and really, really cold for the rest of the time I was there. But I digress. The Anyway, I can't even remember what the hell I was saying because I got off track there. Um, so giving it really was about they probably experience that acceptance, that understanding, like, hey, not only is it not me, but there's something I can proactively do to fix this. Because, let's be honest, right? If you make it to that level, of tier one operator in those communities, you are self-selecting in, and you are tested at the highest levels that we can test anybody. So, a word like lazy or something like that, that's just not even compatible with who they are. And so people want to engage, and they want it, like, if they're problem solvers, and cops are this way too, you're trained problem solvers.
Yep.
And when you can't solve a problem, it leads to frustration. And, I think that's really, I think your work has really given a lot of hope, and given people permission to maybe try things that this quote standard practice of care would discourage, or, maybe look upon, with a, kind of a wink and a nod, or not necessarily take it seriously. And my and maybe you talked with Greenie about this, but my backyard neighbor, God rest her soul, like Sarah Hallberg, she passed away with brain cancer, but she ran one of the largest clinical studies, or the largest clinical study that's ever been done, on using a therapeutic ketogenic diet to uh, reverse and treat type 2 diabetes. And she did it with a high level of success. And one time we were having a conversation, and she was just shocked by the response that she got, where the patients that she was working with were they loved it, and they were just ecstatic that, hey, look, we're getting off medications, we're feeling better, everything's going well. But her professional community, they were circling the wagons and came after her. And
Oh yeah, of course they were. That's
yeah,
I've
and
seen that. I've seen that my entire career. You step out of the lane and everybody pings you to get back into your lane. Everybody around me has done that in my career. Even when I was still a trainee at the VA, I remember having some thoughts about, well, why do we do it this way? And what's we've got these national policies that inform the VA, and they seem counterintuitive and they seem harmful. And I was literally just told, well, it will hurt your career if you go down that path. So just ignore all that stuff. Just pretend it's not there and just keep doing what you're supposed to be doing. I literally was told that from people who are supposedly my mentors.
yeah, yeah,
We
go
saw
along
it,
to get along.
and we see it all the time in other, we saw it with COVID. Doctors, nurses, people who spoke out about other ways of managing COVID, whether that was to prevent transmission of the disease or treatment of it, they were not just ignored or dismissed, they were punished. They were
Oh yeah.
silenced. They were chilled. Their careers were damaged because they had the tenacity or the who do they think they are kind of thing.
Yeah. How do you challenge us? How dare you? Um, yeah, that's yeah, finally I think a little bit of good's coming from that. But
Here's an
anyway,
example. Here's an example of this that I look back on now with astonishment. Um, so I mentioned I've been in three medical schools. Those were psychiatry departments, which are large departments at medical schools. You easily have 120, 150 faculty, and they're multidisciplinary. So you have psychiatrists, psychologists, nurses, internal medicine docs. Usually you're going to have one or two or three geneticists, possibly somebody who has expertise, well, certainly with expertise with brain neuroimaging and things like that. I don't think I ever had a colleague who was an endocrinologist. I don't remember ever hearing a talk or discussion of hormones within these departments of psychiatry. And now I look at that with astonishment and think, how are we people who are supposed to be experts in behavior and emotions and functioning, how is it we just completely ignore hormones?
yeah. And I told you the brief version of my story. Like, I'm lucky. I feel very fortunate that I just kind of stumbled into the understanding of what hormone is, what the hormone insulin is, and what it does, and what its purpose is. And sad to say, at that point, I'm 27, 28 years old, trying, getting prepping for, to make our SWAT team, and I start following this nutrition plan that says, eat 60% of your calories should be carbs, and 25% should be uh, fat, and 15% protein. And that, because that's what marathon runners did. And that's what, if you're a marathon runner, then you are considered healthy and fit. And, but I'm a cop and I'm working the midnight shift, which I loved. And, I wasn't married, didn't have kids. So I would get off work, I would run in the mornings, and then I would sleep, and then I would wake up, and then I'd go to the gym and lift weights, and then hang out for a bit, and then go to work and rinse and repeat. And I never had trouble sleeping even during the day until I switched my nutrition and started doing this quote power diet and eating Wheaties with skim milk on it. Throw a banana on there, sprinkle some granola because granola is good. I know people who have listened to this podcast probably get me tired of me hearing the story, but like within a week, I was waking up within 2 to 3 hours, just starving, like absolutely just ravished. Like, oh my God, I'm so hungry. And so I would have to eat before I could go back to sleep. And I didn't understand what was happening. I was just getting pissed at myself because I thought I was lacking discipline to follow the plan. And
Mhm.
meanwhile, now I'm getting tired. I'm getting grumpy. My workouts start to suffer. And, I find myself in a Starbucks inside of a Barnes and Noble drinking a 20-ounce cup of coffee because
Mhm.
I'm tired and can't sleep. And I open up Barry Sears's book to the page where basically he's talking about, hey, if you're waking up hungry or tired, you probably ought to look at what you're eating before you go to bed. And it was kind of one of those moments where I was like, wow,
Mhm.
that's exactly why I'm here. And then I study, this is what insulin does. It's like you eat a high carbohydrate diet and you're eating all these, processed foods, and your blood sugar spikes and your insulin spikes, and in conjunction with that to get that under control. And all the excess is stored as fat. So hey, you're not eating fat, but why am I gaining weight and getting fat even though I'm not eating fat? Because that was the mindset back in the day. And that led me down this path, and ultimately kind of like, you know it's I was just lucky. I for no other reason, I think I was just lucky, and I paid attention. um and it's a long way of like kind of going into like, I know we're already going at an hour now, so there's a lot of more I wanted to cover. But Kevin Gilmartin, when you talk about like, so that's kind of like the loop, right? I'm getting into this loop where suddenly I'm not sleeping as well, and now my workouts start to suffer, and now my attention starts to fade a little bit. My ability to focus starts to fade a little bit. That and now my workouts are suffering. That puts me at risk at work, and and now my mood's a little bit different.
Yep.
All those things, and it was just one change that I made, one
Let's
little thing sent me down
let's
that
go,
cascade.
but let's go back to that. Why did you make that one change? Because the experts
Yeah.
said, the experts said. And I don't know how many iterations we've had of the federal government's dietary guidelines. We had the
Oh
food
my God.
pyramid, now we've got the My Plate. If you go back and look at these different iterations, I mean, first of all, they're all wrong. Every single one of them is wrong. When did the American obesity epidemic begin? It began in the 1970s. Now, that was a time where fast food and frozen foods and processed foods, were filling up the grocery stores. And it was an era when that's the 70s is when high fructose corn syrup was invented, literally invented.
And
High
added to
fructose
soda.
corn
Yeah.
syrup was invented. It's not even a real food, but we invented this thing that we could use that's one of the worst things you could put into your body. But those food pyramids, those my plates, they've never gotten it right. And if you look at the food pyramid that was first created in the 70s, it's like that is the reason America became fat. We told people, eat these foods, don't eat these other foods, and it was wrong. It's wrong. We destroyed our nation by the experts destroyed our nation. And every time they redo this, maybe it's a little better today than it was in the 70s, but it isn't what it should be. And we've never had an explanation. The experts never come out and with a big announcement, hey, world, we experts, we fucked it all up and we ruined the diet recommendations and we're sorry. And now we're starting over. No, they don't do that.
Yeah.
They
Yeah.
never
Sorry
done that.
for the millions of people that we inflicted with cardiovascular disease.
Exactly.
Yeah. Well, Gary Taubes, was very fortunate to have him on the program with Greenie, and I did an episode with him. Greenie, they're buddies, and Nina Teicholz is another one of people that we pay very close attention to. But he wrote that seminal book, Why We Get Fat, and he came from a science journalist perspective. If you've never read that book, I think you would really enjoy it. But I Yeah. Um, these things are so critical, and so the point then becomes like if what you're doing isn't working, then stop doing it. Like like that's the first thing. Like for me, I don't know what would happen if I didn't pick up that book. I probably would have tried another quote expert's book,
Yeah.
but I found this one that said, "Hey, here's what's happening." It wasn't just here's what this is how you do it. It was a very in-depth description about here are the metabolic processes that are at work when you do this. So if you eat a high processed carbohydrate meal that's also loaded with unnecessary and extra sugars, like you're going to have problems.
Yeah.
And then, we're not, this was even in the era before we understood what trans fats were and and
Right.
and so it was like, oh, okay, well that makes sense to me. Like the logic makes sense. And they've been doing studies on different athletes and sports teams. So I'll try it and see what happens. And I tell people the story. Like I read that book from cover to cover. I went to work with it in my backpack and skipped as many calls as I could to read that thing from cover to cover. And I went to the store before I went home, bought a dozen eggs, some lunch meat, some cheese, some vegetables. I made this gigantic omelet, ate that before I went to bed, and then, I slept like better than I had in like a month. I woke up feeling like a whole new person, right? Like
Mhm,
the
mhm,
like
mhm.
literally, it's like one of those things where you find something that works and the sun's a little brighter, the sky's a little bluer, the grass is a little greener.
Yeah, yeah,
And yeah, then I became the guy who found Jesus, right? You got to read this book, like after I had such
yeah.
amazing results. All I did was change. I didn't change anything except how I was eating. I
Hmm.
had amazing results, and so that's the message, really, like that I'm hoping that we can reach with cops and others around the world because like Kevin Gilmartin, again, going back to him talking about hypervigilance, right? It's an adaptation. It's not a disorder.
Right.
And so,
Yep.
um, you know, if you can't shut it off and if you can't disrupt the adaptation or correct it, then, your nervous system is running full out all the time. It never gets a break. So when you can find these cues or tools or tips or whether it's, professional intervention or something that you can do, at a peer level that you can intervene. Sometimes if you just, correct it at the right point, and man, we could prevent a lot of problems. And I think just going back, like, how many lives could we saved in policing? How many careers could we have saved? How much better could we be, as as a profession, if we started with the foundation of, and again, another Kevin Gilmartin quote, right? Like, let's train our officers how to prevent cardiovascular disease before they have a heart attack, and then
Hmm.
and then spend millions of dollars, trying to maintain them. Let's prep them in advance. Um, I know it's kind of a long segue, but there's a few things I want to cover before we wrap it up because I want to be really respectful of your time. So, um, you mentioned something that again, there's a ton of things. I should send you all the notes that I had from when from reading the book. And by the way, like I did something new with you. Like I'm a hands-on book person. Like I try like this is like Greenie loves this book, right? He talks about it all the time. Ketones, the fourth fuel.
Uh-huh.
Like I
Uh-huh.
like I like to like read and highlight, use little highlighter pens and highlight things.
Uh-huh.
But now I'm trying the digital version where you can highlight with the digital pen.
Mm-hmm.
And
Hmm.
I actually did like it because at the end you can produce a little PDF and I can see like I can compare all the things that I highlighted in your book compared to what everyone else that's reading highlights and then it spits out your notes and
Oh, interesting.
yeah. It's kind of cool. But anyway, so we've talked a lot about like what, you know, or the process, I guess, of what operator syndrome is. But if you had maybe, if you had to explain like 5 to 10 minutes of, okay, here are the steps that we can take now. In your book, it would be like part three that's in your book, right? Here are all the things. And again, I encourage everybody to go read it because there's a ton of detail there. We're just barely scratching the surface. But you get into part three, and it's really, some kind of, the actionable takeaways and what you might be able to do. So I like to give people just a little bit of, if somebody's listening right now and they might be struggling, maybe run them through just like a typical case, a general case scenario about what you would look for and then maybe what you would recommend.
Sure. Well, so just to say, if I may, shameless plug for the book is written for warriors and their spouses. It's not a medical tome. It's not written for an academic audience. It's written to be a practical, readable, relatable guide. And there are I think it is part three. I do talk about the different treatments, but I also provide essentially a generic treatment plan that can be followed. So where do I usually begin? Well, usually it begins with let's the low-hanging fruit are blood tests because that's easy. Get a cardiometabolic panel if you haven't had one, and get a hormone panel if you haven't had one recently. Get those two things. Those are going to provide important data that any practitioner then can respond to and work with. Hormones are complicated, um, in part because we don't necessarily agree on what the cut point threshold should be to define testosterone as, quote, low in a man. Different providers, some use 240, some use 300. I would make the argument that if you're a 40-year-old police and you're below 400, you might be 390, and then you're going to be told, no, you're fine, you're in normal reference range compared to Gen Pop. I would say get a second opinion on that, because that to me is still low from a performance and functioning perspective. So those are two things you can do quickly, blood tests. Um, do you snore? Is your sleep bad? Do you feel tired in the morning when you wake up? Get a sleep study. That means spending the night in a sleep lab with things, leads, wires attached to your body while they measure pretty much every bodily function that they can in a sleep lab. Those are important. Any primary care doc can make those referrals. What a lot of people find though is primary care docs don't necessarily want to order all those tests, and they're skeptical about why they should. So you got to build the case for them. A way to do that is to take the operator syndrome medical paper in with you to your primary care doc and educate them. You can sit down with that you can print the paper off, go through it with a highlighter, circle the things that resonate, and you can take that right to your primary. I hear that strategy works for a lot of people a lot of the time. Another low-hanging fruit is stellate ganglion block treatment. It's a one-time procedure. It's outpatient. It's very safe. It involves receiving an injection of medication into your stellate ganglion nerve center, which runs down our through our central nervous system, and that is our fight or flight. That is one of the places where our fight or flight mechanism originates. And so what stellate ganglion does is it's kind of like putting medication into the nerve of a tooth before the dentist drills on that tooth. It's a similar kind of procedure. It's simple, it's safe, it's been around 100 years. This is not a new treatment. We're talking about a treatment that goes back to the 1920s. And what it does is some people call it a nervous system reset. It takes that physiological arousal that might be hovering around a 7 or an 8 down to a 2 or a 3. And it does it quickly, like by later that day. And those results often last for anywhere from 3 months to years. and so what it does is it leads to almost like an immediate sense of relaxation, of better concentration, because now all that noise is kind of cleared out in the system. Guys report sleeping better. They also report being less angry, less rageful. Wives sometimes refer to it as the anti-asshole intervention that we were discussing earlier. And it opens the door to then being able to engage in psychotherapy or journaling or meditation, other lifestyle changes. So it's a great way to kind of begin a healing journey. And we use this in as a performance enhancer. One of the pioneers of stellate ganglion block therapy for anxiety was a neurologist named Sean Mulvaney and Jim Lynch, two of them working together. They were at Fort Bragg a decade ago, and they were using this intervention to treat headaches. That's what it's historically been an intervention for certain types of headaches, cluster headaches. But they noticed just by accident that soldiers came back a few days later or a week later and said, by the way, I'm sleeping better. I feel better. I'm more relaxed. People say I'm nicer. So then they did the clinical trials and demonstrated this is a really powerful intervention to reduce the physiological anxiety. And then what they started doing was they went around to all the tier one units. They went to they went to pretty much every unit and traveled around. I won't name the tier one units, but I'm sure your listeners know what I'm talking about. And they treated guys on active duty status, some who just come back from deployments, some who were preparing to go on a deployment. And they did it from the framework, from the perspective of this is going to help you feel better and sleep better, but it's also really going to help improve your performance. And so we need you to be lethal when you're overseas. And that's the framework for how it was used. So I'm a fan of the stellate ganglion block treatment. I consider that to be low-hanging fruit because it's so safe and it's so non-invasive.
Yeah, that's interesting. And I don't know that I've heard a lot of discussion in policing circles about that, but yeah, that's yeah, I'm sure people think that maybe I should have taken that a few times myself, right? When you're when you're a police chief, you get accused of being an asshole every once in a while, but uh, that's interesting. What about and we don't have to spend a lot of time talking about this, but I know it's gaining more and more popularity. Um, but things like medically supervised ketamine treatments, and then
Mhm. Mhm.
some of like psilocybin. Some physicians are using, and I
Yeah.
think psychiatrists are using psilocybin. Um, what's the other one? I know that it's right off the top of
Ibogaine,
yeah, ibogaine.
ayahuasca, 5-MeO DMT.
Yeah, so you talk to a police population about that, and then you're going to get a lot of raised eyebrows because a lot of these things, are controlled substances or at some point have been controlled substances. So, there's concern about, well, if I try that therapy, is it going to be, um, am I going to fail a drug test at my organization, or is it going to be
Right.
frowned upon? But I think it's probably time for us to maybe start considering some of these treatments, rather than the alternative, right? And
Yeah.
um,
Well,
I don't know, just just
let me speak to that. And I'll start with ketamine because ketamine is FDA approved for treatment of depression. So there's no concern about illegality there. I don't think there's any, as far as I know, there's no prohibition against ketamine therapy for active duty soldiers or active first responders. Ketamine is a pain medication that has a hallucinogenic effect. It's often used in emergency room operations where a motor vehicle accident victim comes in and they need emergency surgery. They're going to use a cocktail of different things that probably is going to include ketamine to help
it's like a
manage.
dissociative, right? Like a
Dissociative.
medication.
Yeah, it's
Yeah,
a
because they
dissociative. It's used in battlefield medicine. But it's now FDA approved. It's a very effective treatment for depression, anxiety, probably PTSD. One of the things we don't talk about enough, though, is that it is probably actually stimulating neurogenerativity in the brain. So, actually helping promote brain healing by stimulating neurons to regrow, to regenerate, dendrites to sprout, and those neural pathways to become healthier. I've written on, and there are protocols now that combine ketamine and stellate ganglion block together. Um, like, I don't mean like literally at the same time, but like in the same week or month, and that they may even amplify the benefits of each other. Um, a good ketamine treatment usually is 4 to 8 sessions, outpatient, sitting in a clinic while they run the ketamine using directly into the body with a needle. So it's intravenous. The There are other delivery mechanisms, nasal inhalers, tablets. I'm not a fan of those. So personally, I never recommend that, those ways of giving treatments. Then we get to the rest of the psychedelics, the other psychedelics, which are probably considered to be somewhat more powerful psychedelics. And we sometimes refer to them as plant medicine because most of them come from the natural world. LSD is a synthetically produced, but the others are natural world things. Psilocybin comes from mushrooms, for example. So what are those? We did a lot of research with psychedelics in the 50s and the 60s. And then the experts decided that they should be illegal, and we stopped doing anything with them very abruptly. And they disappeared from the medical conversation until the late 2010s. And we now have, so what I know about these compounds is that there is some medical research and there's a ton of anecdotal, you know, information out there from people who've, just done them and used them and tried them. There are foundations that promote and help veterans get psychedelic assisted therapy. I work with and advise some of those foundations over the last few years. Um, we don't know really how these work. They do seem to stimulate neurogenerativity. And so some of the research that's going on right now are literally looking at pre and post brain scans to look at what kind of changes are affected over the course of even just a few days from one journey. Now, I also want to say, I think the research is still very early, so we can't express any true medical confidence that these are should be widely used medications. But I do believe they're safe for the most part when done with medical supervision. So when people talk about microdosing, I'm not a fan of microdosing because that doesn't mean anything other than that's just the Wild West. That's my friend gave me some stuff from his basement that he grew in his basement, and now I'm dabbling with it on my own. I'm not a fan of that.
Yeah, and that's those are the kind of things too, like again, like I get concerned when people talk about CBD like it's like the next coming, like it's the next, and so well, if I'm in a state where marijuana is now legal, then I can just start smoking it recreationally. Yeah, I'm a big fan of definitely having some science to back what you're doing, but also but the process too has to occur, right? Science,
The process is important.
yeah,
It's going to take us a few years. I do believe psilocybin is close to being FDA approved. I think 3 to 5 years we will see the mainstream use of psilocybin into medicine because the studies are so powerful and the safety profile is really good. Now, again, you want to do it in a way that's medically supervised and safe, and you want the stuff to be, pharmaceutically grade sourced, hopefully. The other piece of it is nobody should think psychedelic medicine is a magic bullet that's going to cure and fix everything.
right.
It's part of our, let's call it part of our toolkit. Um, we have a hammers, we have screwdrivers, we've got some wrenches, we've got a tire iron. We've got some things in our toolkit, and we need them all. We don't just use one size fits all for everything. So what I usually say about psychedelics is don't rush and go do that the first thing. Get your hormones straightened out, get your sleep worked on a little bit. Start with the stellate ganglion block. Get some therapy, be journaling, change your lifestyle, get some relaxation, exercise, activities into your daily routine. Um, and then go for the psychedelic medicine if you think you still need it or want it.
Yeah, I think that's really important. Um, I think maybe one of the big takeaways for listeners who have been considering this stuff, and it's one of the things that we have found over and over and over again with people in the labs. Like we look for the LPIR score, right? Like the lipoprotein insulin resistance score, and we look at some other things too, just inflammatory markers. But that marker in and of itself is again, that's like one of those really important guideposts. And if we can move that into the safe range, right? If you're looking between a score of a 0 and 100, anything over 40 is uh, considered insulin resistant. If we can move you, to the left of that, get you, 40 and below, then some of these other issues start to self-correct.
Yeah.
We start to, weight loss is really it scales are important. Like because they can give you a daily feedback about how much you weigh, but a scale doesn't tell you how much you feel, what your energy levels are, how what your joints are doing, how you're sleeping. It's just one thing. It's one of those little measuring points. But when you can start to correct some of these metabolic numbers through using, and what we generally recommend is a therapeutic ketogenic approach, a low carb approach that, good protein sources, high quality fats, and good vegetables. And I mean, that's pretty much,
Mhm.
that's, you know, and the last part's, even somewhat optional if you have high quality fats and proteins. Um, and what we found is a lot of these other things they start to resolve. We've seen it over and over again. So, the problem with it's not just cops. That's just generally my audience. That's who people I work with, and that's
Well,
where
what
I
we're
come
talking
from.
about here is something that affects all of
Yeah.
our country and all of the Western world now. So it isn't just cops, it isn't just soldiers, but yeah, it's all of us. And
Well, they
but
hear
but
someone's
but
doing
cops and fire and soldiers are at special risk because
yes,
of all the other things, because of the else.
absolutely.
Yeah.
All, the shift work and the stress, the repeated exposure to trauma. I mean, yeah, but the problem can also be, hey, I want to bench press 400 pounds. I can't get past 350 and my testosterone's only 600. So like I heard someone else, Larry's taking testosterone. So I'm going to go to the clinic and get my testosterone. And, if you're 30 and taking testosterone, then, you got other things going on that you probably also need to be working on. Don't rely just solely on that to fix you. Um, but it might be something that, because of like what you're talking about, an individual that has this constellation of issues, they might need that therapy. So
Mm-hmm.
and it might be the one thing that puts them over the hump and gets them going. So again, all these things, I like, it's like in cops, especially SWAT operators, people like that, they're used to a threat matrix, right? We
Mm-hmm.
work on these matrix. They help us make determinations about our level of response and things that we're going to do. And so I do think, like, you get your labs done, get your hormones tested, get your lipids looked at, and now you can start scoring your matrix, right? You can start making some decisions about what might help and what might move the needle in the right direction, and get into a treatment plan with somebody that understands you, that's culturally competent, that has the right credentials. And yeah, you could save yourself a lot of heartache, and hopefully what we're looking for is we want to bankrupt our pension systems. We want our officers to live into their 80s and 90s and be healthy and happy and active, not spending the last 12 years of their life, like the World Health Organization will say, right? 3 out of 4 people will spend the last 12 years of their life suffering from an injury or a debilitating illness or injury that could have been prevented from a lifestyle change or, an intervention earlier in their use. So be proactive. I guess that's my message.
There was a there was an interesting something interesting happened this last week. The there was the FDA, Food Drug Administration, held an expert panel to talk about testosterone replacement therapy for men as part of the start to they're reconsidering whether to reschedule testosterone to make it easier for men to receive it, to get it medically. And the meeting was chaired by the FDA commissioner himself, Dr. Martin Makary. And so they had a lineup of, this was Wednesday of last week, December 10th. They had a lineup of, I don't know, a number of identified experts who came and presented on their research or what they know. And it covered a variety of spectrums. But one of the speaker slots was assigned to the US Army Surgeon General. And he didn't present himself, but he tasked an andrologist who's a soldier, major in the Army, to present and told him specifically, hey, it would be good if you talk about operator syndrome. So he did. He went and he presented. You can find this on YouTube. You can find the whole 2-hour panel. But he presented, he's talked about operator syndrome and why we need to be tuning in to this constellation of physiological injuries. And part of that means more attention to hormone health. Soldiers and first responders, I mean, this is me talking now, soldiers and first responders can't meet their fitness requirements and can't optimize performance if their testosterone is way out of alignment. And so I'm glad to see that conversation now starting to happen in more places throughout the medical ecosystem. Uh,
Well, look, when you're secretary, regardless what you think of RFK Jr., right? When he's in his 70s and he's ripping out pull-ups and push-ups, and and a large portion of our population of that age group can't get off the couch.
yeah,
A common sense would say I should be doing what he's doing. Whatever he's doing, I want some of that.
give me some of that.
And
Yeah,
but we don't. Like it's almost ludicrous in a way. People look at that like, oh well, he's taking methylene blue or some, whatever the blue drops he was taking. Like, yeah, that's not the only thing he's doing. The guy's in the gym, he's working out, he's eating right. Like, and there's a shining example of what's possible in your
mhm,
later years.
yeah,
So rather than, yeah, I don't know. And again, we could get back into a conversation about questioning the status quo, but that was, Sarah wrote that, that was, kind of her dying project was she wrote a book and about challenging the status quo. And this is, that status quo thinking is what's getting people killed, right? That's what's filling up hospitals and graveyards. And I think it's definitely time for us to really start thinking differently about how we're going to approach and from my perspective, officer wellness, longevity, and quite frankly, just performance overall. Because the other thing that I try to touch on repeatedly is that this isn't just a personal imperative for individual health. It's an operational imperative.
absolutely.
We need people, like we can buy the best. People talk about, oh, I need more training, I need better equipment, I need better pay. All those things, it could all be true, but if that 6 to 8 inches between your ears and your body are not optimized, then we're just throwing money down the drain with everything else because
That's
it's the person that drives everything that we do. So that's where the focus needs to be first and foremost.
special operations phrase is humans before hardware.
Yeah.
Humans before hardware.
Well, we've been at this for 90 minutes. I'm gonna have Greenie pop on and just say hello real quick before we hang up, if you don't mind. And I could literally spend probably another 3 hours talking to you, but I want to be respectful of your time.
Well, I look forward to our future conversations.
Yeah, thanks a lot. Really appreciate it. For everyone listening, again, we'll put that in the show notes. But uh, operator syndrome, Dr. Chris Frueh. Pick it up. You can do a Google search, and you can find a lot of papers that he's been a part of. But Operator Syndrome, the paper published in 2020, that's out there. And read the book, and we'll be pushing out more information here in the coming months on what we're doing with Saga Health Core and our lab work, because all of these things are very synergistic. And this has been a very I'm just very appreciative of Dr. Freed taking his time, because we know it's valuable, and sharing some of his knowledge and his experiences with all of us. And then also, just lastly and most importantly, thank you for all your service and your work for our veterans. They need the help, and appreciate you. All right, with that, everybody, we'll be 10:42 until next time.